Before we begin this webinar, Viva Learning would like to thank our CE supporter, Health First. Health First firmly believes in the value of lifelong learning for the dental professional. As many of you know, Health First supports tens of thousands of dental offices with emergency medical kits, medications, and devices that help dental practices manage medical emergencies. Thank you, Health First, for your continued support.
Good evening, everyone, and welcome to the local anesthesia and pediatric dentistry. I'm Scott Cohen. I'm a family physician from Bassett Healthcare, and I'm also proud to introduce Stanley Malamed, dentist anesthesiologist. I'll let Stanley take it away.
Hi, good evening, everybody. Yes, this is Stanley Malamed, and Scott and I are happy to be here. Our talk tonight is about local anesthesia in the pediatric dental patient. So I want to go through these five, obviously, areas with you. I want to start out with just sort of an introduction as to the importance of local anesthesia to our dental patient. And this is a paper that was published back in 2004 by Jennifer D. St. George. And it was 10 things that a patient is looking for in a dentist when you're seeking a new dentist. And we don't really have the time to go through the top, the 10 through 3, but take a look at number 2 and number 1. They want a dentist who doesn't hurt. They want a dentist who is able to administer a painless injection. So these are the things that patients are looking for. This is a more interesting. This is the top 10 reasons people hate the dentist. And this came out of the United Kingdom, out of the UK. And things such as the sounds and the smells, the invasiveness of the dental treatment, the drill, the anxiety. But number 2 and number 1, the pain and the needle. So let's take a look on the left-hand side. What they hate the pain, they hate the needle. What do they want? A dentist who doesn't hurt and a dentist who is able to administer a painless injection. The same two things. So the question then is, how do we manage pain in the dental setting? And we are very, very fortunate in the dental profession to be able to utilize local anesthesia. Operating theaters, we use general anesthesia, but in the dental environment, in virtually all clinical situations, local anesthesia is what we do. And local anesthetics, they represent the major drug class that actually prevents pain from occurring. And in our profession worldwide, there are 5 drugs: articaine, bupivacaine, lidocaine, mepivacaine, and prilocaine. I'm giving you generic names because brand names vary significantly from country to country. Well, country to country. I found out a couple of years ago that our profession worldwide administers almost 2 billion local anesthetic cartridges on an annual basis. 1 billion of those cartridges is lidocaine, 600 million is articaine, 300 million mepivacaine, and smaller amounts of prilocaine and bupivacaine. Almost 2 billion dental cartridges. Now, when we talk about how they work, how do we use them? I divide these into 3 categories. So on the left in blue, I have the short-acting drugs. These will provide us with about 30 minutes worth of pulpal anesthesia. And pulpal anesthesia, as you know, drilling, doing root canal work, extractions. Mepivacaine, 3%, no vasoconstrictor, about 30 minutes. Prilocaine, Cedanist, 4%, no epinephrine, about 30 minutes. On the right-hand side in gray, we have the long-acting drug bupivacaine. You probably know bupivacaine as Marcaine or Zorcaine, as Vivicaine, but 90 minutes to 3 hours of pulpal anesthesia and up to about 12 hours of soft tissue anesthesia. That's an excellent drug for post-surgical pain control. Rarely, if ever, used in our population we're discussing here tonight, the pediatric patient. The red category, the intermediate acting drugs, are the most used drugs in our profession. In fact, in North America, 90% of the local anesthetics used in dentistry belong to this category. We have articaine, lidocaine, mepivacaine, and prilocaine, all of them containing a vasoconstrictor, the most used drugs in our profession. As I said, local anesthetics are the safest, and the most effective drugs we have in medicine for preventing and managing pain. And what we're doing is we're using a drug for what it does best, and that is called its indication. So these are the package inserts from 4 local anesthetics. And that's what it says. That local anesthetic, whether it's lidocaine or articaine, mepivacaine or prilocaine, its indication is the production of local anesthesia for dental procedures by infiltration or nerve block in adults or pediatric patients. That's what these drugs do the best. That is their indication. But there is a however, and the however is all drugs, not just local anesthetics, all drugs do many things. Some of them are good, its indication, but some of the things that same drug can do are not. So let's go back to that drug package insert from a couple of local anesthetics. Here's what it says. Accidental intravascular injection may be associated with convulsions, followed by coma and respiratory arrest. And it goes, and in our profession, administering a local anesthetic properly, we can prevent this from occurring almost 100% of the time. Why? Because before we deposit the anesthetic drug, we aspirate. We avoid injecting intravascularly. And we can prevent this essentially 100% of the time. It also goes on to say, the drug package insert, that resuscitative equipment, oxygen, and other resuscitative drugs should be available. So again, keep in mind, I just said that these are the safest and the most effective drugs that we have in medicine for preventing pain. So let's then get into our main subject of the night, and that is local anesthetic for the pediatric dental patient. And start out by looking at what is called the maximum recommended dose, or the MRD. Well, what is the MRD, maximum recommended dose? The MRD estimates the upper limit beyond which a drug's efficacy does not increase, but side effects begin to outweigh the beneficial effects of the drug. In 1994, a medical anesthesiologist, Dr. Rudolph Jong, published what, to me, because this is an area I am interested in, a wonderful textbook on local anesthetics. And in the chapter on overdose of local, he comments about maximum recommended doses. He wrote, "A word about safe or recommended local anesthetic doses as found on drug package insert or in reference books. These doses are best estimates, indirectly derived from experimental studies and clinical case reports. Generally, the upper limits tend to be on the safely conservative side of the fence." Now, keep in mind, and what you're looking at here is the bell-shaped curve. These average doses are based on the middle of the bell-shaped curve, a patient who responds appropriately to the dose of a drug. But 15% of a population are hypo-responders. They need a larger dose of that medication to have a clinical effect. But the other 15% are hyper-responders. And where that's the case, where the average dose of a drug will be too much. So he goes on to say, Dr. Jong, safe doses can thus be either too little or too much, depending upon the circumstance. Vigilance is the watchword.
So Stanley, are you saying here that even if you administer below the maximum recommended dose, that there's still a chance that you could have local anesthetic systemic toxicity symptoms?
Absolutely. The so-called hyper-responder to that drug. So that's why one of the things we are trying to do, which I'll get into right now, is we calculate on a child the maximum recommended dose, but we don't have to reach it. We want to administer the smallest effective dose of that local anesthetic to achieve pain control. We rarely need to get to that MRD. So let's go here and look at what are the contents of your cartridge. And this is simply a chart. You know, a 4% drug like articaine or prilocaine has 72 milligrams in a cartridge. Lidocaine, a 2% drug, has 36 milligrams. Mepivacaine, 3%, 54 milligrams. Mepivacaine, 2%, 36. This is something you need to know. Now, the other thing you need to know when you're administering local anesthetic, mainly to children, but also for adults, is what is the maximum recommended dose? In the United States, the FDA sets that number. In Canada, it is Health Canada. And the numbers are right there. Articaine and lidocaine, it is 7 milligrams per kilo. Bupivacaine is 6.6 per kilo, and prilocaine is 8 milligrams per kilo. But then we have the American Academy of Pediatric Dentists, and these are obviously the specialists in treating children. And I would recommend you just take down the website. It is aapd.org, because any general dentist who is treating a child is held to the same standard of care as the pediatric specialist. So they have guidelines on their website for all aspects of dental treatment. But let's take a look at this local anesthetic for pediatric dental patients. So in the middle, where it says FDA, that is the FDA's recommendations. On the right-hand side, you will see, especially for lidocaine, bupivacaine, and prilocaine, that the American Academy of Pediatric Dentistry recommends smaller doses. Now, my problem with this is that the APD, are using the numbers from one of my textbooks on local anesthesia, an older version of the book, in which I did present both the FDA and I always had it say, it said authors recommended doses, and those were the numbers on the right-hand column. I have since changed that, but the Academy of Pediatric Dentistry, unfortunately, continues to recommend the smaller doses. But the point is this: you calculate the dose, and you don't want to, whatever the number is, whether it's 500 milligrams of lidocaine or 300 milligrams of lidocaine, you don't have to go there. You want to give the smallest dose that is effective in producing pain control. And one more thing about any drug you're using in your practice. In that box is a piece of paper. It is called the drug package insert. It has a lot of information about that drug. And regardless of whether it's a local anesthetic or an antibiotic or an anti-anxiety drug, any drug you are prescribing or administering in your dental practice, read it, because it is a legal document. So we have great drugs. Local anesthetics are great drugs. What is the major drug-related complication that is associated with the administration of local anesthetics? And that's it. It is local anesthetic overdose. Local anesthetic overdose has a new name. It's been around, I'm guessing, 5 or 10 years, relatively new name, but we are now calling this local anesthetic systemic toxicity, and the acronym for this is LAST. All local anesthetics are extremely safe when used properly, and we do. Virtually all the time we're using them properly. And how do they work? Well, on the left-hand side of the screen, you see we injected a local anesthetic. The anesthetic is actually that purple dye, and the drug diffuses. The drug is diffusing in all possible directions. On the diagram, what happened is the local anesthetic is lipid soluble, and it diffuses from the top of the screen, which is the extracellular space, through the lipid-rich nerve membrane into the inside of the nerve. And then the drug will diffuse, travel into what is called the sodium channel. And as you see in the bottom of the picture, it will block nerve conduction. It prevents the propagation of a nerve impulse, thus preventing pain from being felt. So the question is, how does the drug stop working? And very often in my lectures, when I ask this question, that's the answer I get. A drug stops when it stops working because it's metabolized. Well, I want you to know this, and I hope you do already, that metabolism has absolutely nothing to do with the duration of action of a drug. Local anesthetics, as long as they stay in that nerve in a high enough concentration, are blocking nerve conduction. What happens? They diffuse in, then they diffuse out. Now, when lidocaine diffuses out of that nerve, it goes into capillaries, into veins, it goes to the heart, and then boom, it goes everywhere in the body. So the process by which a drug, a local anesthetic in our discussion tonight, stops working is called redistribution. Let's define it. A drug is redistributed from an area of high concentration in its target organs, we'll discuss that in a moment, to other places in the body where that drug does not have a clinical action. What is a target organ? A target organ for a drug is the place in the body where that drug exerts a clinical action. So what are the target organs for local anesthetics? Nerves. Whether it's an intraoral nerve, whether it's the sciatic nerve, the brachial nerve, local anesthetics block nerve conduction. They prevent nerves from conducting impulses. That's what we want. But along with that, there are two other very significant areas where local anesthetics have a clinical effect: the brain and myocardium, the heart muscle. The brain is much more sensitive to elevated high local anesthetic blood levels than is the myocardium. So what you're seeing here, starting on the left-hand side, is the usual progression of signs and symptoms of LAST following the administration of an overly large dose of a local anesthetic. And it normally starts out with signs and symptoms that involve the central nervous system, and in blue, and it can lead to tonic-clonic convulsions. Rarely, if ever, I would say rarely, but a direct intravascular injection of a local anesthetic rapidly, you might go from central nervous system clinical effects into the cardiovascular effects you see on the right. And Dr. Cohen will talk about that in just a couple of minutes. The classic overdose of a local anesthetic is a generalized tonic-clonic seizure. So here we have a chart with blood levels, green and red, of a local anesthetic. The horizontal line, about 2/3 of the way up, is the point, the blood level at which, if the blood level gets higher than that line, that is called the seizure threshold. The patient will have a local anesthetic systemic toxicity and overdose. The green line, which I put in there, is just to show you that when we administer local anesthetics properly, we aspirate, administer, administer slowly, we are very far. We're not even approaching that seizure threshold. However, if and when the blood level gets to that where the arrow is pointing, that is when the convulsion will start. Dr. Rudolph de Jong, back to him again, he made this comment: the brain responds to the concentration of local anesthetic that is delivered to it by the blood, and it doesn't care how it got into the blood at all. So then let's talk about, how does it happen? And the two most common etiologies are, number one, actually second in occurrence, is a direct intravascular injection, and number one is an overly large dose of the local anesthetic. Well, one cartridge of any local anesthetic, 1.8 milliliters of any dental local anesthetic, injected rapidly into a blood vessel. Usually it's a vein, because arteries are very, very difficult, if not impossible, to accidentally put a needle into. But any local anesthetic, one cartridge injected rapidly, will absolutely guaranteed produce a rapid onset of a very severe overdose reaction. But as I said earlier, it's preventable, because when you give your injection properly, there are two things that you're doing. Okay, number one is we're aspirating. And if, as you see in the animation, if you see blood in that syringe, you don't give the injection. You move your needle, you re-aspirate, and if it's negative, then you deposit the drug. We don't inject the drug if we get a positive aspiration. And the other part of it is slow injection. As Dr. Cohen is going to mention, and in the emergency room of a hospital, lidocaine is administered, I won't say routinely, but very commonly, intravenously. We want to avoid intravenous administration, but it's done in the hospital to save lives. Well, for us, slow injection. Slow injection is important for two reasons. Number one, of course, it's much more comfortable for our patient. And number two, if you accidentally administered that drug intravascularly, slowly, a serious overdose of local anesthetic would be unlikely to occur. So it's not intravascular. I've been teaching since 1973, and unfortunately, I've been involved as an expert witness in 27 instances of overdose of local in children. Sadly, the vast majority of them died, and the ones who survived suffered from permanent brain damage. So I want to talk about this. I want to talk to you about the Swiss cheese model of human error. And Swiss cheese has holes in it. And if you were to take 4 pieces of Swiss cheese and put them together, those holes do not line up. So what we're going to be talking about is, this is a scenario. Now, again, not every one of the cases I've been involved with was exactly this. This would be the typical overdose reaction. We have a younger, lighter weight patient, somebody who weighs less than 30 kilograms. Now, if you take a look at the average weights of children from 4 to 7 years of age, and you go to the right-hand column, they weigh less than 30 kilos. So this is the age group where this overdose last reactions are more likely to occur. And the other thing we must keep in mind is that children are not small adults. And you're going to see this in the next couple of steps in the scenario. So we start out with the younger, lighter weight patient in the office of a general practitioner. They're well behaved, the child. If the child had come into that dental office and was screaming, yelling, that general practitioner would likely refer them out to a pediatric dentist. These overdose reactions rarely, if ever, occur in the office of a pediatric dental specialist. So our general dentist, very commonly a recent graduate out of dental school for 5 or so years, trying to build a practice, says, yes, we can treat this patient. And the patient has 20 teeth, 16 of which they have decay. They require treatment, some pulpotomies, some stainless steel crowns. The treatment plan, because of the parent, is 4 quadrants at 1 visit. Now, we don't train you that way. You were not trained that way in dental school. You were trained on a small child. If you're going to treat multiple quadrants, you do 1 quadrant per visit. At the worst, you would do half the mouth today and half the mouth at the second visit. No. This parent insists. I live too far away. I have to miss 2 or 3 or 4 days of work. Parking is so expensive. All the excuses they can give, and you accede to their wishes. Yes, we can treat all 4 quadrants in 1 visit. Again, this is why this happens in the younger, less experienced doctor. This is an example where no good deed goes unpunished. And this would be the first of the holes in our Swiss cheese. The dentist then selects a very good local anesthetic. 3% bupivacaine is excellent when treating a small child in 1 quadrant. What you were taught, what I'm saying right now, is that when your treatment on a young child in 1 visit goes beyond 1 quadrant, you always want to use a local anesthetic which contains a vasoconstrictor. So now we have 2 holes lined up: the treatment plan and the selection of an inappropriate drug based on the treatment plan. So let's just, for a moment, why do we add epinephrine to a local anesthetic solution? Well, if we compare the drug with epinephrine to the same drug without epinephrine, the plain version, we have an increased depth of anesthesia. We have an increase in the duration of anesthesia. Those are the 2 things you love. But the third thing, which is probably the most important, and you don't see it, is that by keeping the local anesthetic in the nerve longer, it diffuses into the cardiovascular system more slowly, and the blood level of that anesthetic will be lower, which basically means we're increasing the safety of that drug. Okay, so now we go to the third of our Swiss cheese holes. And this, to me, is simply incomprehensible. The dentist administers local anesthetic to all 4 quadrants at one time. Absolutely makes no sense. You should inject, if you're going to be treating multiple quadrants, you inject the upper right, for example, you work. 20 minutes later, half an hour later, you inject the lower right. You work. Another half an hour later, you inject the next quadrant, and so on. But nope, they do it all at one time. The drug was administered properly. They aspirated, they injected slowly, but number 9, the fourth hole, they administer full cartridges of local anesthetic. Remember what I said earlier, children are not small adults. They don't need the same amount of local anesthetic to achieve pain control. Now we've lined up all 4 holes. What happens? The treatment starts. And since this drug is a plain drug with no vasoconstrictor, it is being absorbed rapidly into the cardiovascular system. And while the doctor is treating the patient, about 10 minutes into the procedure, the blood level crosses that horizontal line, the seizure threshold, and the seizure begins. So I'm going to throw this now back to Dr. Scott Cohen, and he will discuss the management of the local anesthetic overdose reaction. Scott, take it away.
Thank you, Dr. Melamed. And I do see some questions in the Q&A. Feel free to keep throwing those in there. And what we'll do is, as we get closer to the end, we'll answer some of those questions for you. Stan, you can take a look at those if you like. So, one of the things we want to talk about today is just really the treatment of LAST, local anesthetic, systemic toxicity. But my first thing, and I think Stanley's been hinting that, and some of our questions, really go to that, is you have to avoid it. That is by far the most important thing. So next slide. So when you find it, and remember, Dr. Malamed went through that progression, CNS and cardiovascular symptoms, but some of the earliest symptoms are circumoral numbness, and I'm fully aware that, dental anesthesia is to, in part, provide circumoral numbness, but it's usually not around the whole mouth like we see in medicine or you see with overdoses. So if all of a sudden they're having numbness and tingling around the entire mouth and you're only working on the left side, that's something to think about. Tongue paresthesias, of course, one-sided tongue paresthesia is common with anesthesia and oftentimes a goal. But in this case, it would be the entire tongue, typically, including the tip of the tongue, which is common. Oftentimes people get a lot of dizziness and they have these just weird sensory complaints. They have tinnitus, sudden ringing of the ears, sudden blurred vision. And oftentimes they get these kind of strange, excitatory mental things that happen. They're temporary, but they happen due to the medication's effect on the brain. Remember, Dr. Malamed said that, these medications are lipid soluble. They're soluble in fats, and there are fats in the nerves in the brain as well, and they get into nervous tissue in the brain. But you can get these just very strange things. And I was telling Stan earlier, my first night on call as a resident at Albany Med, it was at 5 p.m. I had a patient with went into ventricular tachycardia, which oftentimes leads fairly quickly into an arrest. And we gave the person lidocaine. He had some very strange symptoms, got a little twitchy and jerky, but we give much higher doses, and we intentionally give them intravenously. But commonly you see there restlessness, agitation, even weird things like paranoia. And when they do have these central nervous system symptoms, they oftentimes do progress to muscle twitches and sometimes to seizures. Next, there we go. Thank you. So, the biggest thing that we see is, in LAST management is no further local anesthetic administration. And Dr. Malamed goes through this whole thing with PCABD, and we really like to follow that. Position the patient that makes sense for the condition that they have. In this case, generally supine. Really check their circulation. They generally will have a pulse unless they got a really huge dose. We have to make sure that their airway is open and that they're effectively breathing. And importantly, if they're not effectively breathing, you'll see why in a moment, that is so important over and above the things we think about, like hypoxic brain injury and things like that. Remember the cases that Stan was talking about as being a witness for, but also definitive care. And in this case, definitive care can be some of the things we're going to talk about in terms of interventions, but also dialing 911. And for one of the things to think about with these, variable symptoms, cardiovascular symptoms, as well as central nervous system symptoms, is like the effectiveness, meaning some people are hyper responders, some are hypo responders, some are just right, to use the analogy. But for all of these events, the onset, the timing, and the symptoms can be highly variable. Most do occur, though, within 10 minutes of drug administration. So if you see a patient who, you think you're out of the woods with that, they can still wind up with significant events 7, 8, 10 minutes later, depending on how much was given and also, how the absorption occurs.
Right,
if it's
Scott.
40
So let me,
Go ahead.
sorry,
Dan.
go ahead. So let me just jump in because this is something that the dental profession needs to understand. When an overdose of local occurs, especially with the plain drug as we're discussing here today, it will occur within about 10 minutes. It is very common in dental offices for a dentist to administer a local anesthetic, leave the room for about 10 minutes. Why? Because it takes that amount of time for a local anesthetic injection to work in most cases. Okay, never administer a local anesthetic to a patient and leave the patient alone. So if you, the doctor, are going to leave that patient, please leave a dental assistant with that patient in the room so that if anything were to start, they can summon you back to that treatment room immediately. Okay, Scott?
Yeah, absolutely. Thank you. That's extremely important. And also if patients are having symptoms, or obviously if they have a seizure, whatever you can to monitor them, blood pressure, pulse, and pulse oximetry is helpful. But this is a graphic that talks about some research that we did, going into this slideshow. And one of the things that I was a little surprised about is the last one there, but 35%, about a third of patients have both central nervous and cardiovascular effects. About a third also just had only central nervous, and about a quarter had only cardiovascular effects. But interestingly, this is the part I thought was a little strange. Only 1 in 5 patients had that weird prodrome we talked about with excitability or circumoral paresthesias and things like that. But about 10% of people who had LAST just had some mild signs or some signs that really just didn't progress at all. So just you have to think about this because it can present in so many different ways and it's so many different time periods. Next. So again, cardiovascular effects, are pretty simple. It's arrhythmias. Obviously, in the past, we used it for arrhythmias. We don't use lidocaine very much anymore. I can't tell you the last time I gave lidocaine IV, and I work in a hospital. But hypotension is very common, and cardiac arrest can be unfortunately common. Don't want that clearly. So remember, this is the key thing, position, supine, feet elevated because of blood pressure. We assess their circulation. It's usually okay during a seizure, not always, but you want to make sure. So assess their airway, make sure it's patent. If it isn't, open it, chin lift, jaw thrust. And also really have to assess their breathing. And we'll get into breathing a little bit in a minute. It is extremely important to make sure you continually assess their airway and breathing, especially after the seizure stops when they're in the so-called postictal or really depressed CNS state. And also, of course, under D, you have to protect people from injury during the seizure. You don't have to put something in their mouth to open their mouth, things like that, but you have to activate EMS and protect them from falling on the floor or hurting themselves during the seizure. So next. Again, getting back to that, it's 100% oxygen, open the airway. And remember we talked before about ventilation. You have to avoid hypercarbia. So hypercarbia, of course, is increased carbon dioxide levels, which happen when people aren't effectively ventilating themselves. And unfortunately, what hypercarbia does is it increases cerebral blood flow. Clearly, hypercarbia and low oxygen, hypoxia, also do other bad things, including affect the brain and the heart. But what they do in this case that is also extremely important is they increase cerebral blood flow. And what that does is it brings more local anesthetic to the brain and it lowers the seizure threshold even further so they can seize. And we'll talk about in a minute, you can actually have secondary seizures in the postictal state, the after seizure state, because patients are now hypoventilating. They're in that very weird postictal state where they're not all that conscious. They're not sometimes breathing that well. We really have to make sure they are effectively breathing or we breathe for them with bag valve mask or whatever you have on hand. Now, hyperventilation, meaning if you're bagging people, that should also be avoided, so don't, bag people like crazy, kind of like a race sort of thing. Really want to bag at 12 to 20 per minute in adults, because over bagging people or over ventilating people can reduce cardiac output in and of itself for a variety of reasons. So next, thank you, Stan. And then D is really protecting people from injuries. We talked about and EMS, but more importantly, if you have access to IV medications and you have IV access, if a person has a prolonged seizure, you can use midazolam, which is like Valium and other benzodiazepines, to terminate that seizure. I would say probably most people don't have that, but it certainly is possible. And if the seizure is unresponsive to IV anticonvulsants like benzodiazepines, there are some practices that keep IV intralipid. Intralipid is interesting. It is a medication that we use for patients who are getting total parenteral nutrition, meaning IV feedings because they can't eat for whatever reason, because it has a lot of calories, but it's 20% fat, as you can see on there. And what it does in this case is, if you remember, Dr. Malaman said that these medications are typically fat soluble. So what this does is it actually binds up the medication and allows the body to get rid of it. And while the American Society for Regional Anesthesia, you can go back one, Stan, says that, it is helpful, intralipid is not 100% effective, and it is certainly not a substitute for following the basic guidelines for monitoring and treatment, but it is an additional treatment in patients who have severe local anesthetic systemic toxicity. So next, and we talked the way it works. So next. So this is an important graphic that we were talking about before, where if you look at what the seizure threshold is when you have a normal CO2 level, meaning if you keep your CO2 level 40 or below in the blood, you generally don't have as high or as low, as a seizure threshold as you do if patients start getting their CO2 levels up. So just very important to remember, and also to remember in the postictal state, not just while they're seizing, but postictally they can have a second seizure if you don't manage their airway and their breathing. Next. So again, post-seizure care, please just don't get complacent, manage patients, look for second seizures, make sure their blood pressure is adequate, make sure their breathing and airway are, adequate. They're in the position of comfort, oxygen if you have it, monitor the O2 sats, and of course, be aware that a second seizure can occur, especially if the patient becomes hypercarbic. Next. And again, as we said before, local anesthetics are the safest and most effective drugs in medicine for the prevention and management of pain, but only when used properly. Stan?
Okay, so let me move on now and discuss one specific local anesthetic. And this is the newest local anesthetic in Canada and the United States. It's Articaine. The two most used formulations, the only two available in North America, are 4% with epinephrine, one in 100,000 and one in 200,000. The market shares you can see in the slide here, it's only been around since 1976, Germany. 98% of local anesthetics used in Germany. Throughout Europe, it's very popular. Let me talk about United States and Canada. So in Canada, Articaine, they got the drug in 1980. We got the drug in the year 2000. And it has now become, in Canada, the #1 most used local anesthetic. In the United States in 2021, lidocaine still maintained first place at almost 45%, where Articaine, only available since 2000, 42% of the market. I have to be honest with you, this is my slide. I like Articaine. I like Articaine for two reasons. I'm going to really discuss only one of them with you right now because it's the one that's relevant to the main theme of our presentation, which is overdose. Articaine is eliminated from the cardiovascular system more rapidly than other dental local anesthetics. And what that basically means is safety. There's an increase in safety. Since an overdose of a local anesthetic occurs when blood levels get too high, and if Articaine is removed from the cardiovascular system faster, it is more safe when used properly. As I said earlier, local anesthetic overdose is more likely to occur in a patient who is under 30 kilos, under 66 pounds, who receives too much of a plain local anesthetic. Well, local anesthetics undergo biotransformation. Another name for this is detoxification, and we tend to call this metabolism in the liver. Hepatic microsomal enzymes break down active drugs into inactive chemicals. But the ester type local anesthetics, the old drugs, the Novocaine, Procaine, chloroprocaine, tetracaine, as soon as that drug leaves the nerve, enters the cardiovascular system, the process of metabolism starts. So let's take a look quickly at what is called the elimination half-life of a local anesthetic. And by definition, it is the amount of time that is necessary for the blood level of that drug to decrease by 50%. So on the right-hand side of the slide, in one half-life, blood levels decreased by 50%. In two half-lives, it's gone down by 75%. We say that a drug is gone from your system, the cardiovascular system, in 6 times its half-life. At that point in time, blood levels decreased by 98.5%. Well, here's Procaine. All right, Procaine is an ester-type local anesthetic. And if you look at the half-lives of the ester anesthetics, they're short. Procaine, chloroprocaine, 6 minutes. 6 times the half-life, gone in 36 minutes. Now, keep in mind again, this process doesn't start until that drug has left the nerve. So this has nothing whatsoever to do with the clinical duration of action of that drug. Now, the amide local anesthetics are metabolized in the liver. So what happens? When your heart contracts, remember, the drug goes from the nerve into capillaries, veins, and then the heart. And when the heart contracts, only 6% of the blood coming out of that heart, cardiac output, goes to the liver. Here's your lidocaine. In pink, that's the amide linkage that all of the amide local anesthetics have. And take a look at the difference in the half-lives. The half-lives of the amide local anesthetics, lidocaine and prilocaine, are 90 minutes. 6 times that is 9 hours. So the amide local anesthetics, once they leave the nerve, will remain in your body, in your cardiovascular system, active for quite some time. Now let's look at articaine. And about 90 to 95% of articaine is classified as an amide local anesthetic because most of its clinical properties resemble the other amides. However, one very important property is like the esters, and that is that 90 to 95% of an articaine dose undergoes metabolism like the esters in the cardiovascular system. Articaine is both an amide and an ester. It's a hybrid molecule. Again, we classify it as an amide, but it has amide and ester properties. This is a paper, a chart from a paper by Dr. Wolfgang Jakob in Germany, where they administered intramuscularly 120 milligrams of lidocaine and articaine, and they measured the blood level over an hour and a half. And you can see it just dramatically how at the end of the study at 90 minutes, the blood level of articaine was significantly lower than the lidocaine. And in fact, if you look at the half-lives, the elimination half-life of articaine in adults, it's 20 to 27 minutes. In children, 18 to 20, I can't read it, but 18 to something minutes. And in geriatric patients, it's about 27 minutes. So here's that chart. In gray, we have the ester anesthetics. On the bottom in black, we have the amide anesthetics, and red is articaine. Even though articaine is classified as an amide, it has a significantly shorter elimination half-life than the other anesthetic drugs. So let me then go right and discuss the use of articaine in children. Okay, and again, we go back to the package insert. And it says, this is Septicaine, is one of the brand names here in the United States. And it says that articaine is available, used in children, adults, and pediatric patients 4 years of age and above. So the logical question, what I'm always asked is why? Why does the FDA only approve articaine for use in children who are 4 years of age and above? And it has to do with the clinical trials that were done back in the late 1990s here in the United States to get articaine onto the market. Phase 3 clinical trials. And this is the paper, one of the 3 papers we published. One was on the safety of articaine, the other was on the efficacy of articaine, and this one was use of articaine in pediatrics. And very simply, this is the abstract, we enrolled in our clinical studies patients who are aged 4 years to 79 years. Well, you know what? What we did is we proved to the Food and Drug Administration that articaine is a safe and effective drug in children who are 4 years of age and above. So here's the question. Can we use articaine in patients who are 2 and 3 years of age? And I have in the lower left-hand side of the slide an American flag, because I'm dealing with what the FDA in the United States is saying. I see online here, we have doctors from other countries. One is a friend of mine from Colombia, Columbia, not the American version of Colombia, Columbia. However, the answer is yes. And using articaine in a child who is 3 and 2 years of age is called an off-label use of a drug, which is perfectly legal. The Food and Drug Administration, they will approve a drug for how, for what it's used for, but not how it's for safety and not for drug prescribing. So they're looking at, is a drug safe and effective? Is this drug articaine? Is this drug lidocaine? Both safe and effective. Do the benefits of using this drug outweigh the potential risks to the patient? So the FDA approves a drug, but not prescribing. And once a drug is out there on the market, a doctor, be they a dental doctor or a medical doctor, is free to prescribe, use a drug for any reason that they think is medically appropriate. Again, this is called an off-label use of a drug. So let's look at articaine quickly in children who are under 4 years of age. And the first paper is 1989. Remember, Canada got the drug in 1980, and Gerald Wright, the chairman of pediatric dentistry at Western University in Ontario, looked at the use of articaine from 2 pediatric dental clinics in the province of Ontario. And 211 patients under the age of 4 received articaine. 29 of them had more than one dosage of the medication. And in some of the instances, the dosage exceeded the maximum recommended dose. And what did they find? No systemic adverse effects were noted on the charts or known to the clinicians. And their conclusion was that the present report provides initial evidence for the use of articaine in patients under 4 years of age. I showed you this. This is the serum levels of articaine. You saw that a little bit earlier. Basically, simply showing you how articaine is eliminated from the cardiovascular system so much more rapidly than other amide local anesthetics. Here's a paper on the use of articaine in children who are under 4 years of age, or actually in children, period. And it's from 2008, the Journal of Pediatric Dentistry. And you can see that in patients who are 2 to 3 years of old, 2 to 3 years of age, my apologies, that 16% of general practitioners were using it, and 10% of pediatric dentists were administering articaine to patients who are 2 to 3 years of age. And the same is true here, that either currently using articaine or ever used articaine in that age group, a significant number of doctors were doing it. The use of articaine in children from the European Archives of Pediatric Dentistry from 2012. And it basically, it talks about how articaine can be used in young children, but it also goes on to state that one of the nice things about articaine, especially in pediatrics, is that you don't need to give that, I'll use the generic term, mandibular block. It works very well by mandibular infiltration. So the block need not be done. And that will eliminate or minimize the risk of self-inflicted soft tissue injury, where a patient will chew their numb lip or chew their numb tongue. A paper from 2020, more recent, again, using articaine in patients who are below the age of 4 and using it in pulpotomies. Okay, and basically, they're saying that, yes, articaine is a safe and effective local anesthetic for pulpotomy procedures in children who are below the age of 4. So with that, I think we have a little bit of time left here for some Q&A. But I mean, let me just finish up really by saying to you that children are great patients. Children need local anesthetics. Local anesthetics, when used properly, are the safest and the most effective drugs in medicine for managing pain. But again, please, please, please keep in mind that children are not simply small adults. The dosage of local anesthetic you administer has to be less. Keep this in mind. The Gauge-Gates mandibular block, the mandibular nerve block in adults, you need to put in pretty close to a full cartridge, pretty close to 1.8 mLs. Children are smaller, and the nerve that you're depositing local anesthetic around is thinner. If a nerve is thinner, you don't need as much local anesthetic. I mentioned this before, I'll finish up with this. If you see an empty cartridge on the tray of a pediatric dentist treating a 5-year-old patient, that pediatric dentist has administered 3 or 4 injections with that one cartridge. Keep that in mind. Okay, Scott, let's go to work.
Excellent. Thank you, Dr. Malama. That was excellent. So let's try to answer a few questions here. Here's one from J.R. Heiss. Could you comment on patients that are little people? How do the doses compare for them being adults, but obviously weighing less than a normal size adult? And I suspect we mean a combination of the dose and the maximum dose.
Right. Well, it's based on body weight. I mean, that's how much more simple can it be? It is based on body weight. So we should have a weight for that, especially if they are, the term using is a little person, you need to weigh them and you calculate your maximum dose, and you don't want to go there, but that's your maximum dose. If that patient weighs 80 pounds, which is 35 kilos, more or less, 7 times 35 kilos for lidocaine is 245 milligrams of the drug. And that's a lot of local. 245 milligrams divided by 36 milligrams of the cartridge, 7 or 8 cartridges administered properly, it would be safe. Again, assuming that patient is a normal responder to that drug. They also could be a hyper responder. So again, be careful.
Excellent. And another one very similar I can take. It's how should we reduce anesthesia doses in underweight children? Same theory. It's based on the weight, whether they're,
Exactly.
a 4-year-old who's 40 pounds or a 4-year-old who's 26 pounds. It's dosed based on the weight.
By the way, that comes from Dr. Milano from Colombia, and he's the one who mentioned. I met him in a meeting in Paris, France last month, and he was wearing a T-shirt that said it's Colombia, COLOMBIA, not Columbia, COLUMBIA. So, hi, Dr. Milano. It's good to hear you or see you again. Okay, why is there no 2% lidocaine? What's interesting about that? There is in Europe. I think Germany might be the only country that has it. Why do we not have it here? We don't need it. Okay, 4%, administered properly, 4% articaine is as safe as 2% articaine. There's no real reason to have another version of it. The two formulations of articaine we have in the U.S. work well. Okay, they work well, rapid onset, good duration of action, and again, they are eliminated from the body faster. So I don't think ever we're going to have in the United States or Canada that we're going to have 2% articaine. It's not necessary, in my opinion.
All right, excellent. The next one I can take is aspiration needed when local anesthetic doesn't contain a vasoconstrictor? And the answer is absolutely yes.
Oh God, of course. I mean, come on, you put any local anesthetic into the cardiovascular system with epi or without epi, you're going to have a problem. Yeah, you always aspirate before all injections. It's the basis of giving a safe injection.
Okay.
You know what? There's a couple of questions here that I don't want to get into because we're dealing with pediatrics here. So there was a question about buffering. We don't have the time right now to discuss it. If that person you have our emails on the slide in front of you, you would contact me. I can send you a lot of information about buffering. I have been an advocate of buffering now since the about 2007. So email me specifically, okay? And there's another one down here, paresthesia with articaine. It's a controversy that is unfounded and essentially is gone. Paresthesia can occur with any local anesthetic. And when articaine came into market in the year 2000 in the United States, any new drug, when it's first put on the market, is looked at much more carefully than older drugs. Lidocaine, 1948, articaine, 2000. So whenever there was a case of paresthesia, and Scott, what for our purposes in dentistry, that means the patient still has some residual anesthesia 24 hours after the injection or beyond. Mm-hmm. It happens. It happened prior to articaine. I started teaching in 1973. Folks, we had paresthesia occurring from lidocaine, from epivocaine. So it's not articaine. It's not. The most frequently damaged nerve is the lingual nerve. Okay, and my feeling, in my opinion, the reason we have lingual nerve paresthesia is as you advance your needle in on an inferior alveolar nerve block, here's the slide. The lingual nerve is in the way. Okay, all injections we give in the human body are blind. Once you insert a needle through skin or mucous membrane, you cannot see where you're going. Now, in medicine, when Dr. Cohen gives an IM injection, one of the things we're trying to do is avoid nerves, arteries, and veins. We want to deposit the drug into muscle. Well, you know what? When we teach you to give a local anesthetic injection in dentistry, what are we telling you to do? We're telling you to aim for the nerve. Aim for the nerve and to somehow magically stop your needle before you contact it, which is absurd. You know, one of the biggest problems we have in our profession with adult patients, and I just gave this lecture in New York. It's called troubleshooting the mandibular block. We miss. It's a hard injection because we can't find the nerve. Well, you know what? If you accidentally contact the lingual nerve or you contact the inferior alveolar nerve, the patient usually feels that zap, that electric shock. You did nothing wrong. You were unlucky. It doesn't always lead to permanent paresthesia, but it could. But again, it happens. End of story. It's not articaine. It's any drug you put in that patient's mouth with a needle and the possibility of contacting a nerve. So I apologize for going on so long here. Pregnant patients. Okay. Pregnancy. Do me a favor, Alex Millman, email me. I can send you a lot of information about pregnancy and local. And you know what local I would recommend? Articaine. Articaine. Why? Because it's gone faster. Okay, it's gone faster. You know, 90-minute half-life for lidocaine, 27-minute half-life for articaine. Now, when a physician, okay, Scott, you're the physician. Dentist calls you up. Healthy female, she's pregnant, she's maybe 7 months or 8 months into the pregnancy, it's going well. Dr. Cohen, I'm the dentist, okay? I have a patient of yours, she's pregnant. We need to do some dental procedures. What do you think about using a local anesthetic which contains epinephrine? Give me an answer for that one.
Yeah, first of all, the amount of epinephrine that you're using is very small. Think about the amount of epi we use in someone with an EpiPen, with an anaphylactic allergy.
Right.
Orders of magnitude higher. The doses are low enough. It's very safe.
Thank you. Because this is a question that comes up all the time. And you being the physician, I wanted you to say that. I didn't know you were going to say it, but I assume you would because you're a good physician.
Absolutely.
Okay. Well, let me see. Can you avoid, from Alan Friedman, can you avoid mandibular block in most pediatric patients? Absolutely guaranteed. Articaine, for a lot of reasons, it's more lipid soluble than lidocaine, mepivocaine, or prilocaine. And by injecting articaine in the buccal fold by a primary molar or even a permanent molar in a young child, you will virtually all the time get profound pulpal anesthesia. Yes. And another part of that answer is we are doing this now in adults. Even though the cortical plate of bone by a mandibular molar in an adult is thicker, Articaine has a very high success rate in providing pulpal anesthesia. Okay. Scott, any final words?
I'm looking on here. There was one more question from Ritel, and there was a question about what is PCABD. Just to repeat, it's position, circulation. Check the circulation. Make sure they're they have good pulse. Airway, breathing, and definitive care. So position, circulation, airway, breathing, and definitive care. Thank you, everyone. I think we're at the end of our time here. It has really been great interacting with you all, and of course with you, Dr. Malamed, as always. Any last words, Dr. Malamed?
Good night.
Good night, everyone,
No,
and thank you very much for coming. We appreciate it.
Viva Learning would like to thank our CE supporter, Health First. Thank you, Health First, for your continued support.